This podcast is about schizophrenia. Schizophrenia has had quite a lot of research done in the field of biological psychology and neuroscience. And so it's a fairly large section in your textbook. So we have a lot that we know about schizophrenia from a biological viewpoint. Schizophrenia literally means split mind. Schizo is split and phrenia, mind. And some people confuse this with split personality or dissociative identity disorder, sometimes known as multiple personality disorder. But people with schizophrenia do not have multiple personalities. Their mind is split or fragmented in such a way that they have multiple difficulties in life, both cognitively and emotionally. But the symptoms are widely varying. So one person with schizophrenia may have very different symptoms from another person with schizophrenia. According to the DSM-5, schizophrenia is a disorder which is really characterized by a deteriorating ability to function in everyday life. So this could affect work life, or it might affect your relationships, or it may even affect your ability to care for yourself. So it could be one or more of those things. And these symptoms, or these signs rather, of the disturbances have to be present for at least 6 months. So it's quite an extended period that you have to have these problems for. In addition, you also have to have at least 2 of the following, and these cannot be attributable to other disorders. So we'll talk in a minute about how schizophrenia is actually very difficult to diagnose because there's a lot of overlap in the symptoms with other kinds of disorders. Okay, so in addition to this general inability to function in everyday life, there has to be at least 2 of these other symptoms present. So one is hallucinations. So you either hear or see or possibly smell or taste things that aren't actually there. That's what hallucination is. It's as though our senses are being stimulated, but in fact they're not. Auditory hallucinations are particularly common in schizophrenia. A second symptom is delusions. This is believing something that isn't true. So for instance, you may believe that you are very rich. That would be a delusion of grandeur. You may believe that you have special powers. You may believe that you have or that you are a special person. Maybe you believe that you're the president or Jesus Christ. Okay, so those are all delusions of grandeur. Often there is disorganized speech. And this is very similar to the word salad that we talked about when we talked about Wernicke's aphasia. So as I said before, sometimes these symptoms are very similar to symptoms that you see in other disorders. And so it's really important to rule out other types of problems before making a diagnosis of schizophrenia. In general, there's grossly disorganized behavior. It's often very difficult to understand why somebody with schizophrenia is doing what they're doing or saying what they're saying. Sometimes there's an absence of behavior. So maybe an absence in emotional expression. Somebody may not be showing any expression at all. Or they may be showing inappropriate expressions, emotional expressions, like laughing when something's very sad. But the absence of emotion or flatness, where there's little facial expressions, there's little excitement, but there's also not sadness, and somebody's affect, their voices seem very flat. There may also be a lack of socialization, so not wanting to be with other people, not being able to maintain friendships, and just sort of behave in what we would think of as a socially appropriate way. But as I said before, the symptoms vary greatly from person to person. And so one person with schizophrenia may look very different from another. And again, it's difficult to diagnose. So I mentioned how the disorganized speech may sound a lot like somebody who has Wernicke's aphasia, but there are other disorders that mimic other kinds of symptoms. So for example, mood disorder with psychotic features. Somebody may have delusions there or even hallucinations. Substance abuse disorder, again, people often have hallucinations and delusions, and their behavior may be very disorganized. So there's overlap there again. And then there's the brain damage things like Wernicke's aphasia, Huntington's disease, and even hallucinations can occur if somebody has a hearing or a vision deficit. That's something that our auditory system and our visual system seem to need to have input, and if it doesn't, it sort of makes things up itself. So those kind of hallucinations are not uncommon in people with hearing and vision deficits. So symptoms of schizophrenia can be divided into 3 broad categories: negative symptoms, positive symptoms, and cognitive symptoms. So when we're talking about negative symptoms, what we mean are not just things that are bad. So negative symptoms aren't bad and positive symptoms are good. You can think more in terms of negative being a minus sign and positive being a plus sign. So negative symptoms are things that are taken away, things that should be there but are not. So lacking in certain behaviors. So lacking in appropriate social interactions, lacking in emotional expression, possibly lacking in speech or movement. Okay, so something that should be there but is lacking. That's a negative symptom. A positive symptom is the opposite. So something that should not be there but is there, right? So something is present that should not be present. So I talked a little bit about delusions on the last slide. So a delusion is an example of a positive symptom because we believe something that is not true, right? So we have a belief that should not be there. So you could have delusions of grandeur where you believe something very good about yourself, but you can also have delusions of persecution where you might believe that perhaps aliens are pursuing you, or you might believe that your professors are in cahoots together and they've decided that they're going to fail you, and so they're all marking your grades down. And if you want to sort of have an idea of what it might be like to experience this, I would suggest that you watch the movie A Beautiful Mind, which is based on the life of John Nash, who was a brilliant man, who he was a mathematician, and fairly late in his life, he actually won a Nobel Prize in economics for the game theory work that he did. But it took them a long time to actually award him the prize, perhaps because of his diagnosis. But anyway, in the movie, you see what it's like to suffer from delusions and hallucinations. And from the perspective of somebody that has schizophrenia, you don't know that these are delusions. You don't know that these are hallucinations. They feel very real to you. A hallucination, as I said already, is when you're seeing things that aren't actually there or hearing things that aren't actually there. And auditory hallucinations are particularly common, and people often report hearing voices. So it might be telling them to do things, might be being very mean to them often. So it can be different things. From a biological point of view, when people hear hallucinations, you see increased activity in the thalamus, in the hippocampus, and in the auditory cortex. Not the primary auditory cortex, but you do see activation in Wernicke's area when somebody is hearing voices. Positive symptoms can also include inappropriate emotions. So perhaps laughing when you should be sad, or it might be sometimes appropriate to be loud and shouting, but there are some situations where it's not appropriate to do that. So the wrong behavior in the wrong place, and sometimes just very bizarre behaviors. It may be a really hot day, and somebody with schizophrenia is wearing a ski jacket and a woolly hat and a scarf. So that might be an example of a bizarre, strange behavior. And then there are thought disorders. So these are difficulties understanding and using abstract concepts, perhaps taking ideas very literally. So that kind of bleeds into the next category, which is cognitive symptoms. So with cognitive symptoms, it's of course difficulty with cognition, difficulty with thoughts, difficulty with reasoning. So difficulty with things like working memory, paying attention, reaction time, having difficulty solving problems, and maybe difficulty speaking. So here's the word salad that we talked about previously with Wernicke's aphasia, but also people with schizophrenia may say things that really don't make a lot of sense. So it's a very common problem is this disorganization of thinking. So schizophrenics, people with schizophrenia, I should say, do and say things that are really difficult to understand. So the lifetime prevalence of schizophrenia is about 1%, meaning that about 1% of people will suffer from schizophrenia at some time in their life. A further 1% would be diagnosed with a milder form of schizophrenia, which is schizoaffective disorder. Schizophrenia is more frequent in city dwellers than in people that live in more rural settings. It can be found in many, many different parts of the world, but it's much more common in the United States and Europe than it is in third world countries. It's slightly more common in men than in women, so the ratio is about 7 to 5. And when it occurs in men, it's more likely to onset in the early 20s. And the onset in women is slightly later, so either late 20s and in some cases at menopause, which for most women is between the ages of 45 and 50. It's very unusual to have children with symptoms of schizophrenia. Adolescence may be when it is more likely to onset. Although there's no one gene that's been associated with schizophrenia, there is a genetic component to it. So we can see that the concordance rate in monozygotic twins is much higher than it is in dizygotic twins. So remember, the concordance rate means that the likelihood if one twin has schizophrenia that the other twin will also have schizophrenia. So you can see for monozygotic twins, the chances are 50% if one twin has schizophrenia. And in dizygotic twins, it's only 15 to 20% if one twin has it. There are other components to being a twin that we haven't really discussed yet in this class, but it's whether or not a twin has its own amniotic sac and placenta. It would be called a dichorionic twin, so if it has its own, but if it shares it with the other twin, it's a monochorionic twin. And so if you're a monochorionic twin, you have a more similar environment to your twin than if you're a dichorionic twin, because you have your own placenta. And so one placenta may be slightly better than the other placenta, and so the environments are going to be a little bit more different. And you can see that here in the concordance rates for monochorionic twins is much higher, 60%, than in dichorionic twins. Now, the majority of monozygotic twins are monochorionic, and what determines whether you're one or the other is when the zygote subdivides. So remember, the zygote is the fertilized egg, and it's going to split and make two fertilized eggs, effectively. Each one is going to develop into a person. And for dichorionic twins, the zygote divides before 4 days after conception. For monochorionic twins, it divides after 4 days. So I guess that's the more common scenario, is a slightly later dividing, deciding that this fertilized egg is going to become twins. So when the prenatal environment is more similar, so monochorionic twins, then the concordance rate is much higher. And if you look on the chart here on the right, you see how if you increase the level of genetic similarity, so the percentage of people that develop schizophrenia increases. So just 1% in the general population, if you have an aunt or an uncle that has schizophrenia, then your likelihood increases to 2%, having nieces or nephews 4%, grandchildren 5%, half siblings 6%, children with schizophrenia 13%, children of schizophrenia adopted by non-schizophrenic mothers 17%, siblings 9%, dizygotic twins 17%, parents 6%, monozygotic twins 48%. That's just about the highest rate that we ever see for any mental illness in terms of genetic elements. And then being the child of 2 schizophrenic parents is also pretty high. It's 46%. Okay, so even though there's no one gene, we think it's a combination of genes, there is this genetic component. But even if you are a monozygotic twin, right, the concordance rate is still only 60% if you're a monochorionic twin. So it's never 100%. So there's environmental factors there as well. So from a genetics point of view, as with all psychological disorders, schizophrenia is not caused by a genetic deficit in a single gene. And research has suggested that perhaps more than 12 different genes could be implicated in schizophrenia. And perhaps the one that's had the most research associated with it is DISC1, which stands for Disrupted in Schizophrenia 1. And DISC1 is the gene that controls development of new neurons in the hippocampus, and also how quickly we get new dendritic spines on neurons. So remember, that's one of the ways that we can get increased gray matter in our brains when we have new experiences. We typically have new dendritic spines, more branching of dendritic spines. But there's something that is disrupted, perhaps, with this gene in schizophrenia. The genes that have been associated with schizophrenia have certain things in common, that either they affect brain development, or they affect glutamate synapses, not sinuses, but synapses, or they affect genes that control the connection between the hippocampus and the prefrontal cortex. But even so, there's more recent research that says it's not about specific genes, it's more likely to involve hundreds of genes. And so perhaps it's to do with mutated genes. So in particular, there may be microdeletions, so little bits of genes that are missing, or microduplications, where a part of a gene is duplicated where it shouldn't be. And these are very tiny little portions of the genes, but it could affect hundreds of genes in an individual. If we look at the statistics, we see that the presence of these microdeletions or microduplications are probably present in perhaps 5% of the population, but they're present in 15% with people with schizophrenia and 20% who have schizophrenia before the age of 18. There's also other evidence that suggests that these microdeletions and duplications may be more common in schizophrenia because having an older father, so a father over the age of 50 at the age of conception, it increases the risk for developing schizophrenia, but it also increases the risk of gene mutation to having these microdeletions and microduplications. So genes are one piece of the puzzle, but it's not everything. There's quite a lot of data that suggests that there may be prenatal influences, so environmental influences during the prenatal period that may also contribute to schizophrenia. And this is generally known as the neurodevelopmental hypothesis. The neurodevelopmental hypothesis of schizophrenia suggests that there's been some kind of abnormality during the prenatal or the neonatal period that impairs brain development. And these could be relatively subtle effects that lead to schizophrenia. So, for instance, it could be related to genetics, or it could be related to the prenatal or neonatal environment, or it could be related to both of those things. So prenatal means before birth, neonatal is the newborn period. So it could be linked, for example, to poor nutrition during pregnancy. We know that babies that are born prematurely or with low birth weight are more likely to have schizophrenia later in life, as well as those that have delivery complications during the birthing process. Also, the mother's blood group has to be compatible with the baby's. So babies that are rhesus positive, who have mothers who are rhesus negative, so that's a component in the blood, these women, or this combination, has twice the rate of schizophrenia. It doesn't affect the first child, but it affects the second and later born babies. And this is a stronger effect in boys than it is in girls. There's also something known as the season of birth effect. So people who are born in winter and in late spring have an increased rate of schizophrenia, so a 5 to 8% increase. And it's perhaps because also there are more diagnoses of schizophrenia when there have been flu epidemics during pregnancy. So it's probably because that viral infections and fever in mother occurred sometime during the second trimester. So that's usually when people are born in late winter, or rather in winter and late spring. The second trimester tends to overlap with the flu season. And we know that having a fever, mother having a fever, can affect brain development. So a fever of 101 can slow the development of neurons in the fetal brain, and a fever of 104 can actually kill neurons in the fetal brain. Also, when you have an infection, you get an increase in cytokines in the mother. And these are good for fighting infection for the mom, but maybe the cytokines are actually harmful for fetal brain development. So if those somehow could affect the developing baby's brain, they may attack neurons in the brain. Also, there's a higher incidence of schizophrenia when there's been some kind of head injury during childhood. And also, if children were exposed to Toxoplasma gondii virus during childhood, they also have an increased risk of schizophrenia. Toxoplasma gondii, it's a parasite, and the parasite can only reproduce in cats, but it can affect humans. I believe it's if you come into contact with the feces of a cat, then you can contract the virus from the parasite. There have been a growing number of studies that have examined the brains of people with schizophrenia using neuroimaging techniques. And you can see evidence of mild brain abnormalities at the macroscopic level, so at the broad level, just looking at whether or not structures are larger or smaller than they should be. And in general, when people have schizophrenia, they have less gray matter, so that's the cell bodies and the dendrites, and also less white matter, so less myelinated nerve fibers or axons. If you look at the MRI scan here, it's a very colorful one, but here you can see that sort of butterfly structure in the center here, and those are the ventricles, right? So those are spaces, and here you can see on the left is the twin that has schizophrenia, and on the right is the twin that does not have schizophrenia. You can see that the ventricles are much larger on the left than they are on the right. And what that means is that the spaces in the brain are larger in the twin on the left than in the twin on the right. And so if there's larger space in the middle of the brain, that means there must be less brain tissue. So that's pretty good evidence for less gray and white matter in the brains of people with schizophrenia. Also, the thalamus is generally smaller than it typically is, and the most obvious deficits that you see in terms of gray and white matter are in the left temporal and the frontal lobe of the cortex. So the left temporal lobe we know is important for hearing and for processing information about speech. So this is why so many people that have schizophrenia have auditory hallucinations. And of course, frontal lobe is vitally important for being able to organize, control, plan, think, working memory. So when we think about disorganized thoughts, frontal lobe abnormalities would be very congruent with that. The dorsolateral prefrontal cortex is particularly important for working memory, and it connects to many other parts of the brain. And we know that people with schizophrenia have deficits in working memory and in attention too. So these effects are seen quite nicely in this meta-analysis of 15 studies of patients with schizophrenia, which included a total of 390 patients across all of the studies. So this meta-analysis was done by Honea and colleagues. And what you see here are a sort of a fictional brain that comes from the meta-analysis. So if, I'm just looking for my laser pointer here. Here we go. So if the area of the brain is yellow, that shows the most similarity across studies. So the yellow areas, you can see the temporal lobe affected and also the frontal lobe, particularly on the left side of the brain. So most studies actually found a decrease in these areas. The red areas of the brain indicate that some of the studies found a decrease in these areas. So you can see that that's more extensive, more of the frontal lobes. But also here you can see the cerebellum is involved, some parietal and occipital cortex, much more of the temporal lobe. And then the gray areas, there's not very much gray here. A little bit here in the parietal lobe, and maybe a little strip here at the top of the frontal lobe. These are parts of the brain which appear normal across all the studies. So this is quite a nice a slide to show you the consistencies across studies. At a microscopic level, so this is when brains have been looked at after death, so doing autopsies of the brain, it's been found that cell bodies, the neurons, are actually smaller than usual, especially in the hippocampus and in the prefrontal cortex. And also there are differences in lateralization. So we talked about the planum temporale, so that area in the temporal lobe that we think is kind of like a brain area that's really important for language comprehension. So having this, we think it's built in, it's there from birth. We usually have a larger left planum temporale than we do right planum temporale. And we think that brain difference, that lateralization difference, sets us up for language. But in people with schizophrenia, they're more likely to have a larger planum temporale on the right side of the brain than the left side of the brain. So it's different from the normal setup. Also, neuroimaging studies of people's brains using fMRI or PET scan have shown that there's less activity in the left hemisphere than there is typically. So maybe there's some subtle changes there, perhaps from early development. And related to this, there's an increased incidence of schizophrenia in people who are left-handed. So there's a genetic reason for people being left-handed, but there might also be a neurodevelopmental reason, that there's been some kind of early insult to the brain, which has made it impossible for the right hand to be dominant. So the left motor cortex is not well developed. And so perhaps something happened during that time, and somebody that was genetically destined to be a right-hander actually becomes a left-hander because of what's happening in their brain. Recently, longitudinal studies, which give us a whole different perspective. So this is when we follow somebody up and measure changes in their brain over a period of time. These longitudinal studies have shown that perhaps the changes that we see in schizophrenic brains is progressive. So it's changing over time. And so maybe cells are actually shrinking rather than dying. But it does seem with these longitudinal studies that most suggest that the changes are happening fairly early on in the onset of the disease. And although there may be some progression, it's not a very marked progression over time. Why is it that we get more schizophrenia occurring after the age of 20? It may be related to the maturation of the prefrontal cortex. We know that that takes a long time. We don't actually think the prefrontal cortex is mature until probably the age of 25, and there's still some changes even after that. And that also explains why we have problems with attention, problems with memory, especially working memory, and problems with impulse control in schizophrenia, but probably also before the schizophrenia onsets. So adolescents who have difficulty with these things also have an increased rate of schizophrenia. So another hypothesis of why people have schizophrenia is called the dopamine hypothesis. And this is the suggestion that there's excessive dopamine activity that's related to the behavioral changes associated with schizophrenia, particularly positive symptoms. And this is based on the fact that research has shown that cocaine, amphetamines, and LSD all increase activity at dopamine synapses, and they are also associated with psychosis and hallucinations. So those delusions that we talked about, and hallucinations. So sometimes it's difficult to know whether somebody has schizophrenia or whether they have abused cocaine or amphetamines or LSD. Also, antipsychotic and neuroleptic drugs that block dopamine tend to relieve positive symptoms. But they're most effective if they're used relatively early after the symptoms onset. And if that's done, many people recover fully, but about 25% of people with positive symptoms don't actually benefit from drugs. Also, it doesn't really explain the time frame of how the drugs work, because if you use a drug that blocks the dopamine receptors, it takes about 2 to 3 weeks for it to actually have a behavioral change, but it's going to affect the synapse within hours. So it's not perhaps as simple as just excessive dopamine in the brain. Drugs that are used to relieve positive symptoms have to be taken often indefinitely, or the symptoms return. And further research has found that generally dopamine levels aren't excessively high in people with schizophrenia. They're normal. But it seems that they have a higher rate of dopamine turnover, which means that the dopamine is being metabolized, if you like, more quickly. It's being used by the neurons more rapidly. And that's what we mean by excess dopamine activity. And in particular, we have many different dopamine receptor types. So one particular type is called the D2 receptor. And it seems that there's a correlation between D2 receptor activation in the prefrontal cortex and cognitive impairment. So the more activation you have of these receptors in the prefrontal cortex, the more impairment you have cognitively. An alternate, but perhaps somewhat complementary hypothesis is the glutamate hypothesis. And this is the suggestion that schizophrenia is related to deficient glutamate activity, particularly in the prefrontal cortex. And because dopamine inhibits glutamate, and glutamate stimulates neurons that inhibit dopamine release, these two hypotheses are somewhat complementary, because if you have too much dopamine, you'll have less glutamate because dopamine inhibits glutamate. And similarly, if you don't have enough glutamate, then perhaps you have more dopamine release. So it may be difficult to decide whether it's too much dopamine and not enough glutamate, because the two actually go hand in hand. So the efficacy of antipsychotics, the fact that antipsychotics work, they work and they support both the dopamine and the glutamate theory. In schizophrenia, there's less glutamate in both the prefrontal cortex and the hippocampus, and it's been shown that there are lower numbers than normal of NMDA glutamate receptors both in the prefrontal cortex and in the hippocampus. And if you remember, the NMDA receptors are very important for long-term potentiation. So if we want to have permanent changes related to learning, we have to have these NMDA receptors. Otherwise, we're not going to remember things long-term. And so, of course, they're important in the hippocampus, but also in the prefrontal cortex. PCP, the drug PCP, inhibits NMDA receptors and produces both positive and negative symptoms of schizophrenia. So that also supports the glutamate hypothesis. because the drug PCP is actually, in its inhibition of NMDA receptors, is actually reducing glutamate activity. And it's kind of interesting because although dopamine is more related to the positive symptoms of schizophrenia, it seems that glutamate is related to both positive and negative symptoms. So we know that people that take PCP have impaired functioning in their prefrontal cortex. If they've had schizophrenia in the past, it might induce a long-lasting relapse. And it's less likely to produce psychotic responses in pre-adolescence. Remember, in pre-adolescence, the prefrontal cortex is not yet fully formed, and so the NMDA receptors are not going to be affected because they're not there yet, or they're not very many of them there yet. So that's probably why it doesn't affect pre-adolescence. Although the glutamate hypothesis, it would make sense if we don't have enough glutamate in our brains that are producing these positive and negative symptoms to give glutamate, we can't actually do that. We can't directly administer glutamate as a treatment, because if you remember back to what happens during stroke, if we produce too much glutamate in the brain, it's going to overstimulate neurons and cause neuronal death. So clearly we don't want that to happen. So instead of directly administering glutamate, instead a drug that is used helps glutamate to bind better. So we can use glycine, which actually helps the binding of glutamate to receptors on the NMDA receptors themselves. So it's similar to the way that benzodiazepines work in twisting the binding site of the neurotransmitter. So it changes the shape slightly, so it makes it easier for the glutamate to bind to the NMDA receptors. So glycine can be used in combination with antipsychotic drugs, but what's different are the antipsychotic drugs treat the positive symptoms, but glycine helps to alleviate negative symptoms as well. One of the problems with antipsychotic drugs is that they act on more brain areas than we really want them to. Remember, these block postsynaptic dopamine receptors, and we really want to target just one system, and that's the let me just get my pointer here for a minute. The mesolimbocortical system. So these are neurons that come from the ventral tegmental area. They go up through the midbrain, through the limbic system, and up to the prefrontal cortex. So we think that the positive symptoms of schizophrenia are caused by overstimulation in these pathways. So the antipsychotic drugs are going to reduce activity in this pathway. So that's a good thing. But it's also going to affect this other pathway here, which is part of the mesostriatal system. And this is more related to movement. So these neurons project from the substantia nigra and up into the basal ganglia. And so if you block this system as well, because inevitably you will, because you can't target just one part of the brain, you're going to get some movement abnormalities occurring, and in particular something called tardive dyskinesia. And this is where somebody kind of tremors, makes involuntary movements, may actually have difficulty moving. So they have symptoms that are very similar to Parkinson's disease. And Parkinson's disease is definitely affecting the mesostriatal system because it's a degeneration of the substantia nigra. So that's the downside of these antipsychotic drugs, is that they have these side effects, these physical movement side effects. And even when you stop taking the drugs, the tardive dyskinesia can actually last for a really long time, for a number of years. So it is a problem with antipsychotic medications. So the good news is that more recently there have been other drugs to develop to treat psychotic symptoms, and this class of drugs is known as atypical antipsychotics, and they include clozapine, which you've probably heard of before. And these don't block D2 receptors. What they do is they antagonize serotonin receptors. So that means they block the serotonin receptors, and also inhibiting serotonin increases glutamate. So again, this is in keeping with the glutamate hypothesis. The good news about these drugs is they don't affect the mesostriatal system, because they're not affecting the dopamine system, they're affecting serotonin receptors, and so you don't get tardive dyskinesia. And the good news is that both positive and negative symptoms are relieved to a certain extent, and so they're much more widely used than the classic antipsychotic drugs that affect the D2 receptors. However, unfortunately, they're not without some risk. So they do tend to decrease white blood cells, and white blood cells are important for fighting infections. They're a part of our immune system. So somebody is more likely to get sick when they're taking these types of drugs. And also it increases the risk for diabetes. So these second generation antipsychotics are typically better, but they still have some issues surrounding them.